This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing the risks of long-term opioid use and a single initial opioid prescription. So how's your night going, Sonya?
Going great. We're kind of halfway through this long recording session, and, the energy's only building. Feeling better and better. How are you?
I'm tired, a long rounding week. I do have some energy right now. And after this, I have to finish a group project with a team for graduate school. So I forgot I forgot how painful that can be.
What about the geezer all-nighter where you just go to bed and then get up really early to finish it?
I've done that. I know you and I are big fans of that when we have our collaborative projects. Just go to bed and wake up at 4 a.m. and roll. Yeah. I don't know if that's going to work tonight.
Oh my gosh. All right. Well, let's get to it. I did want to talk about something for our listeners that was in the news this week with addiction medicine. A few months ago on a previous episode, I talked about alcohol's place in the new federal nutrition guidelines. So every 5 years, our federal government puts out new nutrition guidelines. And as you and I have discussed, research over the last few years has really shown that no level of alcohol improves health. And alcohol in general is something that negatively impacts human health. So while low-dose alcohol, so less than a drink a day, is not likely to cause too much harm, no more than a lot of the other things we do that aren't great for us. If you're a low-risk person, alcohol shouldn't be a recommended part of anybody's diet. The old guidelines, which were 2020 to 2025, those dietary guidelines mention that women should consume no more than 1 drink a day and men no more than 2 drinks a day, which really is sort of higher than the standard, that the data has shown is healthy. And also the newer data also shows about the, not only the cardiovascular, but the cancer risks of alcohol, especially breast cancer, another reason to drink less. So we have brand new dietary guidelines that were just released this month, January 2026, the new RFK Jr. dietary guidelines. And I try not to let my blood pressure go up too high when I read anything about RFK Jr., but it's difficult. The new guidelines, instead of a large document, like fully referenced based on data, it's a 10-page kind of handout document, has no references, has no specifics as to the exact amount of anything. And the alcohol recommendation, instead of strengthening our, concerns about alcohol, the recommendation says, quote, consume less alcohol for better overall health. So I can get behind that. Consuming less alcohol is good for your health. They included a list of groups who should avoid alcohol, including pregnant women, people with alcohol use disorder, and people with medical conditions that could be affected with alcohol. They didn't say what those medical conditions were. And notably, they accidentally left out children as a group of people who should not consume alcohol, because these are both pediatric and adult dietary guidelines. So again, that's okay. But what really raised my blood pressure was Dr. Oz did a press conference and was asked about these guidelines, and he said there was no data to support reducing alcohol consumption. And I'll give a YouTube video of the press conference. You can watch it yourself. He said, alcohol is a social lubricant that brings people together, and, quote, there is nothing healthier than having a good time with friends in a safe way. So he gave that as the reason why they would not be specific and why they would not strengthen recommendations to reduce or eliminate alcohol use. He did say that if he had his way, people wouldn't drink, and that alcohol consumed in small amounts in a celebratory way in some cultures that are generally healthy. But the elimination of these specific limits and telling people to, quote, use common sense, unquote, makes this not really a guideline, just like an opinion piece. And it's not something you can use to set policy. They ignored all of the data on alcohol and cancer. And this is a huge win for the alcohol industry, which has been lobbying hard against changing the U.S. guidelines on alcohol consumption against them. So I don't know. What do you think of the new nutrition guidelines, John?
Part of me, I love the idea of eating more butter, and that's healthy for me. And I don't know if it's facts, but
He also
You
said you
know,
should eat more beef tallow. Have you stocked up on beef tallow yet as a preferred fat?
I had to like read about what that was. 'Cause it's like that's just how ignorant I was. I do think it is interesting though, like with this big drive for this kind of like make America healthy again. You know, the declining American life expectancy is driven by what's called the diseases of despair. And they kind of talk about this kind of, it's almost like a triad. And it's really like, it's alcohol related liver disease, depression, suicide. I mean, they actually list them separately, even though I view this as a spectrum of the same disease, and tobacco. And it's interesting that the MAHA group hasn't targeted any of those, right? That's not, we've targeted food dyes, we've targeted seed oils. I mean, not that these are great things, high fructose corn syrup, but they're kind of like pussyfooting around like the real killer of lifestyle. And I don't know why they won't tackle that unless they just feel like it's going to be so controversial with their base that they're not going to touch it.
Well, because they don't care about actual numbers. They don't care about what actually kills the most people. And I also think there's been I don't know, maybe I'm a conspiracy theorist, but I mean, I think industry lobbying plays a large part in what actually gets done. But no, I don't think the biggest killers, of people in our country are things that the Maha people don't want to make changes on. As you said, the diseases of despair, and then things like gun accidents and car accidents, drug overdoses. They're sort of actively undermining programs that would reduce those deaths, kind of one by one, and distracting us with talk about food dyes. And I think that's why RFK is allowed to continue. He distracts the American people with his like kooky recommendations from what's being done to actually undermine our health.
I don't know. There's something about a guy chewing Zen that just doesn't make me feel like that's the guy I'm taking health advice from.
It's just too kooky. I mean, look, I don't mind if he wants to recommend that we eat less processed foods and fewer added sugars. Like, more power to him. That's great. If he wants to, remove advertising, direct to consumer advertising, that's great. Like, he has some good stuff, but the total rejection of data and the rejection of actual numbers, just I
Doesn't it
can't
make you
stand
question
it.
processed food though? Because I feel like I don't know enough about processed food. I think there is more science there that needs to be done, but I feel like with like, it sounds bad to me, but then all this other stuff he says is bad. I know it's not bad for you. Like, and so now I'm like, maybe processed food isn't that bad. And maybe food dye isn't, because if he's throwing this in with like vaccines and, coming to your healthcare doctor and, I'm like, I don't know, maybe it's not that bad for you.
Processed food is going to be the new sort of, ornery, reactionary behavior.
Yeah. And not to get distracted, I teach the residents, and I like to think I'm like a Uncle Buck type figure to the residents. And the one day I brought them in a bunch of Fruit Loops. I'm like, all right, guys, eat them up quick before the vintage dye box.
You should save the box unopened, and it could be a collectible.
All right, okay, back on track.
All right, but I don't know. So I mean, honestly, the only thing that is a saving grace is I don't think Americans actually paid very much attention to the dietary guidelines, no matter when they're written. People just do what they want, and the biggest drivers of food consumption, I think, are the food industry and advertising. So maybe people won't really pay attention.
Well, I mean, most people weren't aware that like the food pyramid was removed in 2011, 15 years ago, and we're talking about how we need to, redo it. It's dead.
It's long gone.
It's dead.
Yeah.
Now with ankle high socks, it's gone.
Ankle high socks are coming back.
Yeah, I wear them, but my kids tell me that's how they know I'm old.
That's the only reason you're doing good. John, is there anything in addiction news you wanted to share this week?
Yeah, I saw kind of an interesting article. I know this topic comes up a lot. It's just more of a erudite discussion, but it's called Timeline of BC's 3-year drug decriminalization pilot project. So, I'm somewhat embarrassed that I'm not as versed in foreign affairs as I wish I was, but I was not aware that British Columbia has had a ongoing pilot project where they were basically decriminalizing a small amount of drugs, with the idea being that they wanted people to get into treatment and to not kind of incarcerate, put people behind bars for kind of minor drug use charges. And so this pilot has actually been going on for 3 years, and actually British Columbia is going to be ending it as of the end of January. So January 31st, 2026, they decided not to extend this initiative any further. And really, it started in January 31st of 2023 with the pilot saying that you could have up to 2.5 grams cumulatively of drugs, which included like opioids, cocaine, methamphetamine without criminal penalties. So not enough to be distributing, but like personal use amounts of drugs. And the idea being that, instead of putting you in jail or sending you away for something like that, that it would offer you treatment, and that would be a way of getting people into treatment, not necessarily being punitive. They did amend it throughout the process where, they made it only applying to people in their homes, people that were experiencing homelessness, overdose prevention sites. So kind of not general public, but kind of areas where there was more controlled or private. So it's kind of an amendment after a year. And really, from a public policy perspective, it's interesting. It's very mixed. They talk about that there's a fair amount of academic literature showing that during this time frame, they've had fewer overdoses. They've had more people uptake into treatment, and actually reduced criminal justice involvement. So from an academic perspective, they actually say that they feel it was very productive. But actually from a public persona perspective, it was not viewed very positively. And so because of that, it's got a lot of pushback, and that's why it's being removed. And yet the most interesting thing to me about that is, I know that we fight this battle with public perception regarding these things here in the United States. I always kind of viewed Canada as a little bit more open-minded and kind of progressive with these types of things. So that surprised me.
Yeah, I mean, it surprises me too. I do think that people remain open-minded until there's a certain level of public disorder, at which point people become less open-minded about it. But no, I mean, I don't know the numbers. It can't be cost effective to use the criminal justice system as a way to kind of manage drug use. And, despite our, at least here in the US, our massive numbers of incarcerations, it hasn't made people stop using drugs,
Yeah.
And it's so expensive. Think about money it costs to have a person incarcerated. You could channel that money into treatment societally, and then, maybe make a bigger difference.
I feel like that's my kind of biggest bugaboo with it is I think it's the right thing to do, like morally. I know that moral compass is different for each human being, but I feel like morally it's the right thing to do. But from like a fiscal perspective, it seems like such a waste of money.
Yeah. Incarceration overall seems like such a waste of money. I don't understand why everybody's not just on house arrest. Just do that. Unless you're truly psychopathic and you're a total danger. I mean, most of my patients who keep going to jail, they just stole stuff from Walmart mostly.
But that's a 50%. I don't know. I think Jeffrey Dahmer, I don't want him on house arrest next door. But
he can go to jail. But like my poor people who just stole stuff from Walmart, they could just be on house arrest. They don't need to go to jail.
Yeah. Or the 50% of people that have nonviolent drug offenses that are currently incarcerated. That's a group. I mean, we strip that group out. That's half of the criminal justice system.
Right. Think how much money we'd save.
Yeah.
Interesting. Well, thank you for sharing that. You ready to hear about our article?
Yeah, let's do it.
So this was a super interesting article. It really made me think back to my time of, when I started practice here at St. Max's, and, just think about opioid prescribing in general, because as well as doing addiction, I am a primary care doctor. So I do prescribe chronic pain medicines, and I do worry about them a lot. I teach residents. That's a big part of my job. And I want to make sure I'm giving them correct information and setting them up for a successful practice. And so this was an article. It was published in the Journal of Drug and Alcohol Dependence, and it was about the influence of the initial opioid prescription on the risk of long-term opioid use. So basically, if you were an opioid naive person and you got a first prescription for opioids, what was the chance that a year later you would still be on them? And what were the characteristics of that first prescription that were associated with long-term use? With the idea that if some of the prescriptions are more risky than others, perhaps we can focus on the lower risk types of prescriptions. And the reason this is really interesting to me is that this exact same study basically was done quite a while ago and informed some of the guidelines we put in place that we put in place when we realized we had a prescription opioid epidemic, and we're prescribing too much and harming people. And so the question is now, in this new era of reduced and restricted opioid prescribing is, do we still have to worry about it? Do I still have to be so anxious about my opioid prescriptions? Or now that all these new safeguards are in place, do I have to worry so much about my single prescription for someone who's having dental work or something like that? So that's why I was really interested in this study. It's been shown that a single opioid prescription leads to long-term opioid use or increases your risk of long-term opioid use and your risk of developing opioid use disorder. But all these studies were really based on sort of administrative claims data starting in about 2006, which was a period of, unchecked opioid prescribing in our country. And I really know this because, I took over my current practice in 2008 when I started at St. Max's. And I adopted a large number of patients on high-dose opioids as well as benzodiazepines and had to go through the painful process of kind of weaning people off and getting their prescriptions to be a little more coherent. And it was a very difficult time. So I was sort of interested to see what modern data shows. So, John, do you feel still anxious about prescribing opioids to your patients?
I feel less anxious than I used to, just because I feel like I think a lot of it when I started, a couple things. One, things have gotten a little bit better for this. Like, I think, when you have like a 8-year-old with back pain of undetermined etiology on like 800 morphine equivalents from a PCP for 13 years, like that's a hard conversation. And it's also tough because those were hard. I think now I have some patients on chronic opioids for pain, all on lower doses. And I'm very comfortable with all of them that I'm currently prescribing to. So it doesn't bother me. I think as long as I'm doing it safely and it's kind of with shared decision, I'm following them, it doesn't make me as anxious.
Yeah. Yeah, me too. I agree. I feel every patient I have now on chronic opioids, I feel very comfortable with, and I would easily advocate to continue those opioids because I do think they're the best choice for the patient. And I see a lot more support in other providers for reducing opioid use. I'm not seeing surgeons continue it endlessly. Surgeons have been the biggest champions at reducing opioid use. The perioperative opioid prescribing really went down before and after these new guidelines from 2016 from the CDC were released about opioid prescribing.
Yeah. And it's hard because I feel like the longer I do this, it's almost, this is a weird take for an addiction medicine podcast. I actually feel like some of this has now gone to the underside of the pendulum too far. Like I have some people that get referred to me from other physicians because they get a new doctor and someone's on, someone with end stage renal disease is on 5 milligrams of oxycodone twice per day at age 87. And, their new doctor won't prescribe it. And it's like, that's kind of an appropriate indication at that point. I mean, there's reasons these medicines exist, and sometimes you don't have another option for pain. And I don't know, it's shared decision making with the patient, I think, at that point.
Yeah. Yeah, agreed. So in this article, let's talk about the clinical question. So basically, like I said, it looked at opioid naive people age greater than 14 that had filled at least one opioid prescription between April 13th, 2016 and April 18th, 2020. So 2016 to 2020 is the era of this study. So of those people who filled that first prescription, what is the median time to opioid discontinuation? So how long are they on the opioids? And what is the risk of long-term opioid treatment, meaning greater than 1 year, when you compare the duration of that initial prescription, the type of the opioid, and the pain indication? This was a large insurance database study. It used the IQVIA PharMetrics Plus database. It had 578,000 plus people in it, so a huge sample. And they included anyone, as I said, adults who had got at least one opioid prescription, adults and adolescents, and then had up to 6 months worth of continuous insurance enrollment prior to their initial opioid prescription. They excluded people who had cancer, who had substance use disorder, who were dispensed an opioid indicated for substance use disorder like buprenorphine, if they didn't have information in the database, or the prescriptions were missing key information. So basically, as long as all your information existed and you weren't being treated for cancer or substance use disorder, you could be in this study. They looked at the characteristics of that initial prescription. So what was the indication? how many days supply, what was the average daily dose, and what was the type of opioid. And then they looked at the outcomes. So, as I said, how long till people stopped the opioid? What was the cause of pain? And they looked at other covariates like age, sex, geographic area, payer type, what year they got their index prescription, if they received other meds like hypnotics or muscle relaxants, and if they had a mental health condition. People were followed for a mean of 184 days, so at least half a year. And remember, most people stop their opioid, after a single prescription. So they didn't need a lot of follow-up. They were followed from their index date until they either discontinued their opioid, reached the study end date, or were no longer enrolled in a insurance plan that put them in this database. So, John, what do you think of the clinical question?
I think it's a very interesting way of looking at this. I mean, it is a question I think a lot of us have is, what is your risk with these prescriptions? And I'd be interested to see what comes out of this. I've seen similar studies before. I'd be interested to see if the themes come out the same.
Yeah. So strengths of this trial, it was really big. I thought their statistical analysis was appropriate. They included some just descriptive statistics, but also the Kaplan-Meier curves and hazard ratios. They did do an intention to treat analysis. I thought it was very relevant. There was a clear dose response effect that would sort of improve the plausibility of the association. The follow-up was long enough. They made a really clear comparison between their data and previous studies done prior to 2016, which I was very interested in. And I didn't think funding would cause bias. It was funded by the NIH and University of Arkansas for Medical Sciences. There were some limitations, though. The biggest problem is that this is a prospective cohort study, and the groups might be different at baseline. Like, it doesn't take a genius to think that the person who gets 5 oxycodone as their single prescription has got to be different in some way than the person who gets 90 OxyContin. They're just not the same. I mean, maybe it's the same, but I would think that the groups are all different at baseline, and those groups might have different risk factors for long-term opioid use. The other issue is that this is an insurance database, so it only includes patients with insurance and insurance claims, so it misses self-pay events. And so a lot of people actually do get chronic pain medicine from self-pay cash-only pain management clinics, and they wouldn't be captured in this database. They didn't have complete data on pain etiology. They were missing it in 39% of patients. And the other thing is that population before and after 2016, when our big opioid prescribing guidelines came out, were not the same. The more recent people getting opioids were older, more likely to reside in the West compared to the East, more likely to have commercial health insurance, more mood disorders, just different other medications. So the sort of before and after comparison, the two groups weren't exactly the same either. Another possible limitation, there are other risk factors for long-term opioid use that aren't captured in a database like this. So pain severity, psychosocial status, behavioral variables like illicit drug use, smoking, alcohol, substance use disorder history, those weren't captured. So if you acknowledge those limitations, I think it was a pretty good study. You just have to be clear at what the conclusions are. All right, you ready to hear the results, John?
Yeah.
So, I'll just summarize. In one sentence, I would say that in this era of more conservative opioid prescribing, increase in a day's supply remains the strongest factor associated with a higher likelihood of long-term opioid use. So if you gave people a lot more initially, they were more likely to continue long-term. Overall, so the overall risk is that 5.05% of people continued opioid use for greater than 365 days. So 1 in 20 of those initial opioid prescriptions led to a full year of opioid use. So that's pretty high. If you think about all the surgical prescriptions, the ones that are meant to be short-term, 1 in 20 of them led to long-term use. The likelihood of opioid discontinuation was lower with a higher day's supply. And that day's supply of the initial opioid prescription influenced the likelihood of continued use beginning basically on the 4th day. So up to days 1, 2, and 3, it didn't make a big difference. After about 3 days, you started to see that increasing association with increasing days supply. The people who had the highest likelihood of continued opioid use were those who received long-acting opioid. That was high risk. 32% of those had long-term opioid use, followed by tramadol, about 9.9%. Oxycodone, short-acting oxycodone, was the least risky at 3.68% and had the lowest likelihood of continued use at 1 year. People who had chronic non-cancer pain had the highest likelihood of continued opioid use. That was 7.89% continued use at 1 year. So those were sort of the big results.
You know what's surprising about that? The long-acting opioids, right? So that means that 70% of long-acting opioids are not being prescribed chronically. That's surprising to me, right? Isn't that like looking at the enantiomer of that? I'm like, that I feel like we prescribe, like with pain management guidelines and recommendations shifting away from long-acting opioids. Who's the 70% of prescriptions for short-term long-acting opioid prescriptions? That's kind of a bizarre practice pattern.
Right. Who's using long-term opioids as their initial prescription?
That's interesting.
It is interesting. I mean, and that goes back to my point about the limitations. I mean, if I have a patient with a horrible chronic condition and I don't anticipate it to go away, and I think opioids are the best treatment, I would start, I guess, with a long-term opioid, but I probably wouldn't. I would start with short-term and work my way up to long-term.
Yeah, I think like
I mean, not
long-acting
short-term, like
opioids
like short-acting and long-acting, sorry.
I think even chronic pain guidelines now, they're kind of favoring more short-acting kind of multiple times throughout the day than the long-acting ones due to the risk and you know, kind of like tachyphylaxis people get from this. This confirms to what I've seen now like 4 or 5 times. Tramadol is the wolf in sheep's clothing, right? It is. I mean, this is like every study, it's tramadol. And I think it's because we often feel, you know, is it really that tramadol leads to that, or is it that if we're doing chronic opioids, we all feel most comfortable with tramadol? I mean, I don't know.
Right. I mean, I think that's kind of
potato.
Yeah, but it's kind of true. Like, am I super upset that my like person with horrible plantar fasciitis takes 2 tramadol a day long term? I mean, not
Wait, you're
really.
prescribing tramadol for plantar fasciitis?
Hey, no judgment here, man.
Get the ice bottle out of the freezer. Come on, man.
Oh my gosh. But you're right. Like, I view it sort of as a non-harmful medication, and I use it sort of as like, or I have used it in the past as like a first-line opioid before I would do oxycodone. But it's such a dirty drug. You know, it activates all these receptors. And I think people like it a lot. A lot of people tell me, you know, I took that Percocet and felt really sick. I don't really see people saying that about tramadol.
And there's some mixed results. I've seen studies showing that people are more functional on tramadol than on the other opioids. I don't know. You're right. It's interesting. I mean, tramadol is kind of like dipping your foot into chronic pain.
Yeah. I mean, St. Max's addiction psychiatrists have strongly advised against tramadol use. I think they don't like it because it activates like multiple receptors all at once. So you can't really tell exactly what it's doing.
It's kind of interesting that chronic non-cancer pain had higher likelihood of continued opioid use over cancer-related pain. I mean, that surprises me too, right?
Yes and no. I mean, a lot of cancer-related pain is temporary, though. You know, you get treatment and then you're better. Whereas if you have chronic pain, like, it's hard to get better.
I don't know. Like everyone on hospice.
Yeah, but that's, you know, not to be morbid, but you're also not having long-term use then.
All right.
Sorry, that was a little grim. But again, bottom line, the opioid prescriptions most associated with long-term use were tramadol and long-acting opioids. And the opioid diagnosis most associated with long-term use was chronic non-cancer pain, about 7.89%, really eclipsing all the other diagnoses. And the days supply that was associated with long-term use, the longer the days supply, the more long-term use you saw. So up to 4 days, it was about 2%, 2.7% of people transitioned to long-term use. And after that, it escalated. So day 5 and above, the percent who continued long-term use really took off. And the highest, of course, is greater than 3 weeks, so greater than 21 days. If the initial prescription is greater than 21 days, about 33% were still on opioids at a year. And of course, it's not just the cause. Like, if you're giving someone an initial prescription that's greater than 3 weeks, like 4 weeks or a month, as a doctor, you're anticipating long-term pain, you know? So it's not surprising
Yeah.
at a year you might still be having that same pain. So those are the results, comparing it to the data pre-2016. And again, for anyone who doesn't remember, 2016 is when the CDC released these opioid prescribing guidelines that really tried to rein in chronic opioid prescribing and all opioid prescribing. And they were pretty prescriptive. They did cause a lot of patients actually to be taken off their medications, maybe for worse. But if you compare it to pre-2016, fewer people were initially prescribed opioids for extended periods in this current era. But not that many fewer. So 2016 to 2020, 11.91% of people were prescribed 8 or more days supply on their initial opioid prescription, whereas about 15.5% prior. Slightly fewer people continued opioids for at least a year. Current study, it was 5.05% of initial opioid prescriptions were continued for a year. It was 5.3% before, so not a huge difference, actually. Kind of at the population level, fewer people were transitioning to long-term opioid use, and the rate of prescribing initial opioids with a long initial day supply is decreasing. But if you do get a long initial days, a high day supply, it confers the same excessive risk of long-term opioid use as prior to 2016. The only other thing about this study is that the majority of subjects received their initial opioid prescription in either 2016 or 2017, when old prescribing habits were still in place. Substantially fewer subjects initiated an opioid in the years following our data after 2017. So I think we could repeat this study yet again now 10 years later and probably see a lot fewer opioids. So will these results help me in patient care? Basically, I have patients requesting opioid prescriptions all the time in both indicated and non-indicated situations. Just recently I had a patient come ask me for additional opioids after her surgery because she still had pain and her surgeon had said he wasn't going to give any more. So she came and asked me if she could have more post-op opioids. The risks of opioid, in terms of transition to opioid use disorder, transition to long-term use, opioid adverse effects, the benefits are analgesia. This study doesn't tell you if the opioids worked or if it was worth it. I can't really make a risk-benefit decision for patients using this study because, like almost all studies on opioids, they really only show the risks. There's no data on the benefits, just the harms. But the risks of transitioning to long-term opioid use are unchanged from prior to our 2016 guidelines, and we should really not let our guard down regarding opioid prescribing. Initial prescriptions should be limited to 4 days or less. So how this will affect my care, I will definitely keep any opioid prescription to under 5 days if it's a new prescription. I'll focus on short-acting oxycodone or hydrocodone acetaminophen combo. I'm not going to assume that tramadol is safer or less addictive. I haven't started anyone on tramadol in a long time. I've got the one patient with, some plantar fasciitis. I got another older lady with arthritis, but I don't actually have a lot of people on chronic tramadol, and I won't assume that it's going to be safer. So that's how this will affect my practice. How about you, John?
I think it's interesting ideas. I think it's not going to be practice changing for me. I think it reinforces a lot of my current practices. I feel like, I feel like very limited in my doing short-term opioid supplies at all anymore. I feel like just there's so many other pain options for many patients. Occasionally I'll have to do something if like a surgeon can't be reached and a person's having like intractable pain crisis after a surgery, especially with the surgeons now giving like 3-day scripts for a lot of these bigger procedures. They're not giving these long prescriptions, but yeah, I think it's interesting. I don't know. The tramadol thing, I think I could go either way. I could play devil's advocate for that one too. I feel like I know it has its own different kind of like side effects. And certainly like people with renal dysfunction, higher doses, it can definitely cause seizure. I don't know. If I'm going to pick between chronic tramadol, like 8 morphine equivalents of tramadol versus, even a low dose hydrocodone at triple that, I don't know. Is it really that much worse? I'd be interested to see the safety differences.
Yeah, I've seen people who have opioid use disorder with tramadol as their drug of choice, but I haven't seen anybody like have a serious complication from tramadol other than that I've prescribed. But I've definitely seen people with serious complications from oxycodone, even like 5 milligrams a few times a day.
I don't know. I've seen complications from tramadol, especially like at the hospital, like seizures, right? So,
Yeah.
I think it's something you do gotta, like, you don't get that with the other ones. So I think there is its own set of things you have to look out for tramadol. But I don't know. I think it still goes with my themes. It's like, is there other pain medication options? Is it the lowest effective dose? Is there shared decision making? I do incorporate discussions now about like opioid-induced hyperalgesia, which is in some of the newer guidelines, because I think most patients aren't aware of that. And when they hear of that, they don't like that idea. And I think I must be doing something right, because I think out of the last like 5 patients that I said that, we're out of options, that I've offered an opioid prescription to them on a chronic nature, I think 4 of the 5 declined it.
Yeah. I mean, I think people do listen to the news a little bit. It's funny. I have a small handful of chronic opioid patients who I prescribe chronic opioids to. It's not a very big group. And I sort of thought they would be on them forever. And 2 recently both told me, without me saying anything, they wanted to taper off. They were just sick of them.
I also think with the tramadol, I think that some people just gets the shits of it and they just stop it on their own. And it's a low enough dose that oftentimes you're not dealing with these massive withdrawals. I feel like you're right, because some people are just like done with it.
Yeah.
I feel like I see that with tramadol. I've had patients that like just stop showing up and they're like, yeah, just don't take it anymore. I didn't feel like coming in every 3 months.
Right. Benefit's not worth it.
Yeah.
It's another fact. I know it's a little bit off topic. As an addiction doctor, it's funny because I think one group I prescribe opioids to that is not buprenorphine are my patients with opioid use disorder. Because I've had so many issues when my patients have surgery that
that no one wants to touch it, right?
I call the surgeon now and I say, look, please don't prescribe them anything. I will take care of all the pain management issues regarding this surgery. And the surgeons are thrilled. And then I do prescribe, if the patient wants, like short-acting opioid agonists for a few days post-op if they want, as long as they stay on their buprenorphine. So it's kind of funny now I prescribe opioids to that population after, working so hard to get them off it.
But that's short and appropriate, right? Yeah. I feel like, in fact, I'd love to see, I think sometimes we undertreat pain in this group post-op.
Yeah.
And I think there's a lot of, it must be very difficult when you go into the hospital and you have a serious surgery and that's on your chart. And, to have to ask for most medications as needed, right? So I feel like every time I have to ask, it's probably hard to do that.
It is, although some of my patients have been so strong and have really wanted to avoid any full opioid agonists, even with pretty massive surgeries, and have gotten through it fine.
Yeah.
So people
I had a guy with thoracotomy, just took his bupe and he was good.
Yep. I had someone with spinal surgery. I've had amputation, knee replacement, no extra opioids. And that was by choice. I didn't force that on anybody.
All right. Well, we got a nice talkback message here from the article. The author of the article we presented in episode 68 about the value of adding behavioral health treatment to buprenorphine. Dr. McHugh writes, quote, "We tried to be extremely careful not to give the message that a script alone with no psychosocial support was recommended, and you captured that perfectly. Wishing you luck with this project, and thank you for what you're doing to advance the field." So that was nice.
Yeah, that was awesome. Thank you for listening.
So that can offset the 45 kratom emails we got about how you guys are crap.
And I'm ready to get some tramadol emails too. If you got any thoughts about tramadol, just send them our way.
I don't know. I think you and I are on different teams on this one a bit.
Team tramadol. Or not. Team no tramadol.
Ideally none of the above, but sometimes you gotta. All right. Well, that was cool. Well, thanks for presenting that article. Good discussion. Similar themes from what I've seen before. So I think when you start seeing these themes kind of reemerge repeatedly, it's probably pretty close to dogma at this point, right?
I would think so.
Yeah, this episode's getting long, but I would like to not know the patients. I would like to know the who of the prescribing, right? I would like to, because I don't think that there's a bell-shaped curve of prescribing patterns. I do think that there's outliers that take up a large percentage of opioid prescribing. And I know every community I've ever worked in, there's always one or two out of hundreds of doctors, but it's one or two that do the majority of heavy damage here. I would like to see if that's true, universally. Is it really 1 or 2% of our population of providers that's accounting for a disproportionate number of the scripts, and what's going on there?
Yeah, it's true. And who are these providers? Well, perhaps with the miracle of, our modern EMR, we could produce a report that gave exactly that information.
All right.
I'll let you know.
Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support by My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you and have a great day.